Gladly. Fatigue and physical exercise, it's almost an oxymoron, because usually when you're tired, you're supposed to get some rest. So saying that physical exercise is indicated in case of fatigue is a bit provocative in Western culture anyway. This has already been discussed, so I'll try and be brief, because if you want to mention everything in the literature in terms of clinical studies, there's so much. So it's difficult to look at everything and to list everything. But the key messages are not that many, because if you want to sum up, fatigue can be treated with physical exercise. It's actually the only type of intervention that has proven to have an impact. Once you've worked on the other sources of fatigue, anemia, but also endocrine diseases, pathologies. So, to put it in a nutshell, we don't know exactly everything about the physiopathology of that type of fatigue. It was still early days, so we don't know what the mechanism of action is, even though we are exploring a few leads. But I'm still a bit, circumspect when it comes to all the data about inflammatory activity. But I'd like to share my personal take on this, because I try to actually really use it in my practice. So I think we need to be very practical. We're moving towards clinical studies that with few patients that sometimes don't ask the right questions, because so much has been written. And if you look at what's happening on the international level, some studies seem to want to reinvent the wheel and really don't. So I think we're moving towards a situation where physical exercise only is mentioned for a minority of patients. It's something of a flavor of the month. And if physical exercise were a drug, we would have everybody take it. And the question, the reality is that to have someone practice it on a daily basis is tricky. It's not easy. So I'd like just to pick up on a few key messages, because a lot has been already said. But there's been French study, an Amgen cross-prospective study, and we're hoping to publish it. And 2/3 to 3/4 of patients reported fatigue as the most common symptom. So fatigue has been the number one functional complaint before pain. And in this study, we've tried to raise awareness amongst oncologists and nurses to try and have them realize that it's a reality and that it needs to be managed. And you see here that it affects all types of cancer, really: breast cancer, lung cancer, colorectal cancer, or non-myeloid myopathies. And whether you're a doctor or a patient, of course, perspectives vary. Fatigue is attributed by a lot of patients to chemotherapy treatment. For physicians, it's more attributable to cancer. And the notion of anemia is not well known by patients. So physicians are the ones identifying anemia as one of the first causes of fatigue, not patients. If we look at the perception of the intensity of fatigue, it's a little surprising that when we use visual analog scales, many physicians do not assess and do not assess patient fatigue. Because if you look at stage 9 to 10, 16% of patient assessed fatigue versus 3% by physicians. So let me gloss over this because time flies, but it's part of the elements that impact quality of life. Okay, once you've said that, what do you do next? The greatest number of publications currently have to do with the role played by cytokine. Well, and it seems that chronic fatigue in oncology would be linked to inflammatory phenomena that would result in an abnormal expression of cytokines. So, if we look at the literature, there's a very good review on this by our colleague Bauer, but you have to be careful with studies because most studies are on a small scale, so they need to be backed up, and they're not always consistent in terms of results. Another risk factor is genetic polymorphisms. We're not all equal when it comes to fatigue, but there's very few publications, and there are clusters that actually are predispositions for fatigue. And there are other factors that are good predictors of fatigue. Body mass index, when you're overweight, you tend to feel more fatigue. And similarly, and we find it in other functional complaints by patients, in the anti-aromatase related pain, pre-treatment fatigue tends to be amplified when patients go on chemotherapy. So pre-treatment fatigue tends to get worse. So, and that's not always really taken into consideration enough. So symptoms get amplified on chemotherapy. And so much so that it begs the question, is there no underlying common mechanism? Because we now know that chronic fatigue in oncology is not a hidden depression, because we've made a number of tests with antidepressants, and antidepressants didn't help at all. So, but fatigue, depression, and cognitive disorders might still be linked, which would make for a multi-factor model where you would have a combination of factors that have to do with the cancer treatment and other clinical factors and other biological and social and physical factors, which would end in symptoms such as fatigue and other disorders. So, what is it we know? What kind of evidence do we have on the mechanism of action? We know very little. We know that patients who feel fatigue find that they are in a vicious circle and they will get less and less active. And, you know, ever since we were born, we were told that when we felt tired, we should rest. And it's been also proven in a number of studies that after treatment, the fact that you have a low level of physical activity is correlated with fatigue. And we also wonder if there's no correlation with BMI, because we know that, for example, with breast cancer, there's quite often a weight problem. And one last point that I'd like to insist upon, we often underestimate the purely psychosocial impact, because we always tend to have a biological and scientific perspective on this. But quite often when we worked on physical exercise for people who, for example, had no job security whatsoever or were in a difficult situation, and most of them had ear, nose, throat cancer. So it's probably these patients with serious pathologies and who are no longer really part of the fabric of society that are most vulnerable. So we looked at the quality of life score, and well, that's nothing new. We know that physical exercise helps when you feel fatigue. But what surprised us is that the same level of benefits, what patients told us, is that it really helped because it actually recreated that social fabric that they had completely lost touch with. And the fact that they got to see people again put them back in a virtuous circle, and they would then join health education programs, they would make friends and would join nutritional groups, and quite a lot of them see their situation improve, and I think that definitely plays a part, and I think that's underestimated. But we have so much data, but I'll try and be brief. That's that's data from the BMJ. And physical exercise helps with everything. When you practice a sport or a physical activity, in terms of quality of life, mental functions, it helps with pretty much everything. And I think that was probably shown in the previous presentation. There's a Cochrane review on this very subject. And when there's physical exercise after cancer, you not only improve your fatigue scores, but your depression score. So how does it work? I really tried to find out if there were physiopathological data. There's very few, there's very little in terms of physiopathological data. It's hard to sort out, but there's a small series with papers in not very renowned publications. So that's a paper that was published in the Immune Network. That was not an oncology paper. So very few looked at the specific effect on cytokines in oncology. And if you look at TNF-alpha between the control group and people who exercised, it's not conclusive. Is it really linked to cytokines? I spared you the rest of the study. So I'll give you a very personal conclusion, really derived from my practice. Fatigue is still, as I explained, underestimated in cancer patients, quantitatively and qualitatively. It is the number one functional complaint. There is one treatment that is proven to be effective. It's physical exercise, and it's not being used enough. It needs to be encouraged more and used more in clinical practice. But there's a few questions, and actually quite a few questions that are left unanswered. What kind of physical activity for what patient? To be very brief, if we consider that physical activity and all the specialists in sports medicine, they all say that it's a therapeutic intervention, and that a therapeutic intervention should come once a diagnosis and a prescription by a specialist has already been given. So if we stick to that, logic of cocooning and physical activity, regardless, with guidelines that are mostly common sense but not much more. That how people tell us that we should walk for 30 minutes every day, or that might be good, but is that going to be appropriate for all patients? You have to look at the treatment profile, what's what's going on in terms of chemotherapy, with the cytokines for that given patient. And we need to find out more about cytokines for all patients. So depending on the type of treatment, we have to customize physical activity. And what about barriers to physical activity? I'm not going to show slides, but I'll say two things. In Bobigny, we conducted a study on barriers to physical activity in a department that's very proactive in terms of physical activity, and where we have the infrastructures, and we have only a handful of patients who come and are involved in physical activity. And those barriers are really silly. It's very mundane. It's transport problems, problem of finding a childminder, and there are also psychological barriers and educational barriers, and there's also the question of long-term management. We have data from the Nutrinet study. There are currently 150,000 people who have filled in questionnaires about their lifestyle on the internet, and we're getting an idea of physical activity before and after treatment, and there are more patients who actually reduce their physical activity after treatment compared to before. So a year after treatment, patients seem to have ceased to really practice physical activities. You have to look at what kind of support they received, what kind of program they participated in. But there's that begs the question: what can you do long term for these patients, to help these patients change their lifestyle? As long as we have only cosmetic and short-term programs, we won't achieve much. I know it's difficult to implement, but I think we'll come upon those obstacles. I hope I wasn't too long, because after physical exercise comes the comfort of food to keep your energy balanced. So I thank you for your attention.